Hello and welcome to the Supportive Care Services virtual Lunch and Learn series. We've created a series of Lunch and Learn videos to help you be successful when navigating your cancer journey. Our Supportive Care Services department is here to help you get actively involved in your healing process. For more information about the Supportive Care Services department, please email socialwork@ironwoodcrc.com.
Hi everyone, I'm Dr. Rashmi Vaidya. I'm a breast surgical oncologist with the Ironwood Cancer Research Centers in Phoenix, Arizona. Today I just wanted to take you all through what it is like for a patient to be first diagnosed with a breast cancer and what are the questions to be asked. What would a surgical consult look like? What should they expect? A lot of times these questions don't come easily, naturally. Patients are scared and confused as to where to look and where to find the information, and too much information seems to be coming at them too quickly. So I would like to walk you through getting the diagnosis and coming in for a surgical consult. So let's say we have Miss ABC. She had an abnormal mammogram and she went in to the radiologist. They did what's called as a diagnostic mammogram to get more details regarding her mammogram and the abnormality. They then went on to do an ultrasound, and then they recommended a biopsy, which they did the same day. They told her it was a small lesion, about a centimeter in size, and a few days later she got a call to say that it was indeed a breast cancer. Her primary care physician set her up with a breast surgeon for the initial surgical consult. She's now here in the office. When we are seeing a new patient for a breast cancer, we do a lot of information gathering in the background. We would like to know where the imaging was from. I like to look at the images myself to know what the cancer is like, where it is, and what the rest of the breast tissue looks like. We like to know the size. We like to know whether the lymph nodes looked abnormal or not. So these are all the pieces of information that ideally we like to gather before the patient even gets there. We also like to know the surgical pathology from the biopsy that was done. And this pathology report has a number of pieces to it. It talks about the type of cancer. It has words such as invasive versus non-invasive. And I'll get into the meaning of that. But it also talks about the size of it. It also talks about the grade of it. And it's a lot of detailed information that sounds like medical jargon to normal people. What it helps us do is it lets us analyze at a preliminary stage what is the biology of the cancer and how best to treat it. So we look to get this information as well before we meet the patient. When I'm meeting the patient for the first time, we do go through a history to find out if there was any previous history of cancer, whether there's any family history that's relevant, whether there's any personal history that's relevant, such as exposure to a chest wall radiation for some kind of cancer like a lymphoma, or history of having taken combined hormone replacement therapy for more than 8 to 10 years, which is a significantly high risk factor. Next, we do a physical exam, focusing mainly in the breast and in the axilla, which is the armpits, to look at abnormalities that are obvious on physical exam, whether by inspection, by looking, or by palpation, by feeling it. Next, we look at the imaging together with the patient to explain to them what was seen, and finally the pathology report. So a lot of times people are confused as to the stage and the grade. So the stage refers to the size of the cancer that is being seen on imaging thus far. So something that is less than 2 centimeters is considered a stage 1 cancer. Between 2 to 5 centimeters is considered stage 2.
Stage 3 is when the cancer is larger than 5 centimeters. There could be some lymph node involvement. Sometimes these cancers are eroding out through the skin or are even stuck to the chest wall. This would be considered what we call as locally advanced breast cancer. or when it has been there for a certain time and grown to quite a size. Stage 4 is when the cancer has gone to other parts of the body, such as the lung, the liver, the brain, or the bones. So stage 3 and stage 4 are what is more advanced cancer. Stage 1 and stage 2 are considered early breast cancer.
Next comes the grade. The grade refers to the activity level of the tumor that is seen by the pathologist when they look at the biopsy pieces of the cancer under the microscope. Between a 1, 2, and a 3, the lowest activity level is a 1, 2 is sort of middle of the way, and 3 is a higher grade. That gives us some clue as to what kind of treatment would be better suited for the patient. The higher the grade, the more we feel that it is a more active tumor. It could be helped by more intensive therapies. Then we come to the status of the estrogen and progesterone receptors and the Her2 protein expression on the cancer cell. 70% of breast cancers are responsive to estrogen and progesterone. What does that mean? It means that these hormones, which all women and all of us, including men, have in our bodies, are driving the cancer cells to grow. So they are acting like growth factors for these cancer cells. How does it help us to know this? Because down the road, once the surgery and other treatments for the cancer are completed, it would help these patients that are estrogen and progesterone receptor positive to take medications that would block these hormones in the body so that they are not able to feed the cancer, thus minimizing the risk of the cancer coming back either in the breast or anywhere else in the body. The next is the Her2 protein. So that is a protein which is present in about 30% of cancer cells. If it is present, it means that we could offer the patient targeted therapy, which is anti-Her2 therapy, which is more of an immune therapy rather than chemotherapy, and it works very well. And so that would be a required part of the arsenal of the treatment for Her2 positive cancer patients. We find extremely good responses to anti-Her2 therapy, and so it has become the mainstay. And sometimes, in fact, for cancers that are larger than 2 centimeters, it is something that is recommended to be done before surgery to shrink the size of the cancer and really to treat the whole body before even getting to treating the breast cancer surgically. That is called neoadjuvant therapy. And it works very well for certain kinds of cancers. Like I said, for the Her2 positive cancers. It also works very well for triple negative cancers. What are triple negative cancers? These are cancers that are estrogen and progesterone receptor negative and Her2 negative as well. And these are particularly the kind of cancers that respond uniquely to chemotherapy. And so chemotherapy done before surgery is able to shrink the size of these cancers and decrease the amount of involvement of the lymph nodes with the cancers as well, allowing us to perhaps do a smaller surgery, a less invasive procedure in the armpit as well. So these therapies are called neoadjuvant chemotherapies or neoadjuvant immune therapies. A lot of times they need to be combined together to be most effective. The particular regimen that would be used for a cancer depends on the health of the patient, the health of their heart, their liver, their kidneys, and what the physician and the patient agree on is the best regimen for them, given the biology of the cancer. When we are trying to decide should a patient have chemotherapy before surgery versus after surgery, the deciding factors are whether it would change the type of surgery. So if a patient comes with a large tumor and it would be impossible to offer her anything but removal of the entire breast at the time of presentation, and if we have the option of doing therapy that could shrink the tumor in the breast, decrease the amount of tumor burden in the armpit, then that's a good way to start her treatment as soon as possible and yet be able to do a more conservative, a more limited surgery. So in these cases, we do discuss doing chemotherapy or immune therapy or both chemo and immune therapy ahead of doing surgery. For the most part, for early breast cancer patients, we usually will recommend surgery before any other treatments such as chemotherapy, radiation, or anti-hormone therapy. The reason is that no matter whether we do surgery first or chemotherapy first, the outcomes are the same. There is no difference in survival. As far as the choice of surgery goes, the options are between a lumpectomy versus a mastectomy. Lumpectomy being removal of the cancer with a rim of normal tissue around it, versus mastectomy is the removal of the entire breast. From a medical standpoint, the indications for a mastectomy are if you have multicentric cancer, meaning multiple spots of cancer in that breast, which are each of them at least 5 centimeters apart from each other. So if that's the case, that's a lot of tumor burden to have in the breast, and it would not be wise to try to cherry pick these areas of cancer and try to still save the breast, because the chances of the cancer coming back in the remaining breast tissue is quite high, even if we chose to do radiation after that. Hence, currently, we recommend mastectomies for multicentric cancers in the breast. The other indication would be if you had a very high-risk pathogenic mutation found in your DNA testing by doing genetic testing, which shows that your risk for getting lifetime risk of breast cancer is up to an 85%. That is found in some mutations such as BRCA1, BRCA2, PALB2, PTEN mutations, BARD1 mutations. There are many other mutations which increase your risk for breast cancer over a lifetime. And if we find a patient who has a strong family history, has breast cancer herself, and is found to have such a mutation, that would mean at a lumpectomy may not serve her as well, because then she would be incurring the risk of a lifetime of much increased risk of breast cancer, despite all the treatment for the index cancer. So other than these two specific indications, there is no other medical indication for mastectomy. The high-risk patients, such as those who've had mantle radiation for their chest wall for lymphoma, or very high doses of combined hormone replacement therapy, such patients, if they come with breast cancer diagnosis, those patients will sometimes make a choice to consider a mastectomy as well, because of their increased risk, substantially increased risk, which can be up to a 40% for a lifetime risk for breast cancers as well. Patients often ask us, well, if we have to get rid of one breast, why not just get rid of the other breast? So that's called contralateral prophylactic mastectomy. Again, the only settings in which it would be medically recommended would be the presence of a very high-risk pathogenic mutation, such as the ones we discussed just now, or having multiple cancers in that breast. So in the absence of those two indications, for a small early breast cancer in one breast, there is no medical benefit to removing the other breast. Breast cancers typically will travel to some other part of the body, such as the lymph nodes first, and subsequently other parts of the body, such as the lung, the liver, the brain, the bones, before they travel to the other breast. So it's not really natural for a breast cancer to travel from one side to the other. However, there is a small increase of a risk of a new breast cancer developing in the other breast. But given the treatments that are being used systemically, this risk is very small, and the cancer, if it occurred, would be something that would be detected on imaging, which is done as part of surveillance after treatment of breast cancer. So contralateral prophylactic mastectomy is usually discouraged unless we have very strong medical indications to do it. When patients have a genetic mutation, we do discuss it, and we offer immediate reconstruction with the mastectomies as well. We involve plastic surgeons to work with us to offer that immediate reconstruction. Whether we are doing a lumpectomy or a mastectomy, we do what is called as a sentinel node biopsy, which is evaluation of the lymph nodes in that armpit to look at whether or not the cancer cells have made their way to the lymph nodes. How does this information help us? It helps us to know how best to tailor the treatment. How much of radiation does she need, or can we get away without radiating the armpit at all? What is the role of radiation in breast cancer treatment? So the recommendations are, if we are trying to remove the cancer and leave the rest of the breast intact, that is a lumpectomy, and that needs to be followed with radiation to minimize the risk of the cancer coming back in that breast or in that armpit. That completes what we call as breast conservation therapy. And walking away from radiation after a lumpectomy because we got good margins would be a mistake, because that increases the risk of the cancer coming back in the breast. What about systemic therapy? Well, systemic therapy has gotten more and more sophisticated as time goes on. And today, for cancers that are small, early, and expressing the estrogen and progesterone receptors, we do a test on the tumor tissue itself that tells us the biology of the tumor, that lets us know whether this is a cancer that is best treated with chemotherapy, or is this a cancer that would be better treated with finishing the radiation after a lumpectomy and subsequently going ahead for anti-hormone therapy. So we are able to select patients that would truly benefit from doing chemotherapy and then recommend it for those patients. So this is the spectrum of everything that we discuss at the time of the surgical consult. We also involve our medical oncology colleagues and our radiation oncology colleagues so they can speak to their parts of the treatment in more detail and shed more light on the nuances and the selection points for their treatment. If there are any questions, I'm happy to take those.
Good morning. Today we have the opportunity to speak with Dr. Vaidya on some common breast cancer and breast surgery questions from our patients. So good morning, Dr. Vaidya. Thank you so much for joining us.
Oh, thank you, Sierra. Glad to be here.
Great. So we will get started. We have a few questions here for you. Beginning with, after a breast cancer diagnosis, many patients experience high anxiety, some depression. How can our patients combat that?
That's a great question. Yes. So getting that phone call from a radiologist or a surgeon, whoever did the biopsy, is very anxiety provoking, and it's paralyzing because there are many decisions to be made on the personal and professional front and on the treatment front as well. So I find that yoga helps cancer patients, and I've been recommending it to more and more of my patients. And it is the mind-body connection and the holistic approach of yoga that helps you reduce the stress, which in turn will hopefully decrease your inflammation in the body, the chronic inflammation, and hopefully let you have better coping skills with the diagnosis and be in a better frame of mind when you are approaching treatment decisions.
Great. And now yoga can be something for beginners as well as advanced yoga professionals. Is that correct?
Right. So for cancer patients, we are not talking about doing advanced yoga, though. We are talking about doing simple things like breathing exercises, doing meditation, doing relaxation therapy, doing guided imagery, doing simple postures that are helping you stretch out the muscles and generally helping you relax. So because when we do that, when we are able to relax, we upregulate our parasympathetic nervous system, which helps us rest and digest, and downregulate our sympathetic nervous system, which is responsible for fight or flight reaction. So reduce the stress, improve the relaxation.
Great information there. And we also do have a pre-recorded video of Dr. Vaidya with some instructions on some basic yoga moves. So please reach out to our website and YouTube, and we can go ahead and help you with that. Now, some other questions that we have here. Will a patient always need a surgical biopsy to confirm their breast cancer diagnosis, or can they receive that confirmation through simply lab work?
No, you never can tell from lab work whether there's a breast cancer. I know there is a lot of what they call as liquid biopsies out there that look at some cells and some mRNA and things like that. Really, the confirmatory test for a lump in the breast that looks suspicious or some calcifications that look suspicious is a minimally invasive breast biopsy. And by minimally invasive, it means either an ultrasound guided biopsy that we do in the office using local anesthetic. People tolerate it very well, and it's a very quick procedure that gives us a diagnosis within 48 hours. The stereotactic biopsy, again, is a similar outpatient procedure which is done for calcifications. If there are suspicious calcifications in the breast, they get sampled in a similar manner. The technique is different, the imaging required is different, but it gives you an answer again in 48 to 72 hours. And these are, the standard of care, that minimally invasive surgical biopsies. Sometimes it's very hard to get to certain areas in the breast. And for some people who, for various reasons, are not able to tolerate a minimally invasive biopsy, an excisional biopsy may be performed, but it is not ideal because that means you're trying to do a surgery just to get to a diagnosis, and the woman may need further surgery to actually treat the lesion if it happens to be a cancer. So that's not optimal management. We usually like to get a minimally invasive biopsy, know what we are dealing with, plan the care, and then go in for surgery for definitive management of that breast cancer.
Great. Now, some patients have a mastectomy, others have a lumpectomy. So for patients who have to have a lumpectomy, are they able to conserve that nipple and areola area of their breast?
Most of the times. So unless the cancer is directly involving the nipple areola or is directly underneath it, kind of stuck to it, only then would the question come up of whether or not that can be saved. In most other cases, as long as the cancer is not involving that area and is somewhere in a different part of the breast, it could certainly be saved in the setting of a lumpectomy. In fact, that is the goal of a lumpectomy, to try to do it by saving the nipple areolar complex and doing what we call as oncoplastic surgery, where we move the gland. So the breast tissue, the gland is moved, it is freed from the skin, and it is also freed from the underlying muscle. So in two planes, we move the breast tissue, and once we remove a cancer, we move together that gland so that we can suture it together to close that defect. So we are not leaving a hole after a lumpectomy. So that's oncoplastic reconstruction. We do it all the time for our patients with lumpectomy so that they don't have a cosmetic deformity at the end of the surgery, while we are still trying for oncological safety. So we are still trying to get good margins around the tumor, but at the same time, leave her with a breast that is not deformed.
Great, that's a great option for our patients. Now, how long does it typically take to recover from a lumpectomy versus a mastectomy?
Right. So with a lumpectomy, these days both are outpatient procedures. So unless the patient has opted for a complicated reconstruction involving 8-10 hours of surgery, in that case she's definitely kept in the hospital for about 3-4 days. But otherwise, for lumpectomy or mastectomy, typically, unless there's been an unusual incident in the OR, typically patients expect to go home because they have a better recovery at home. We send them home with very good pain control because of the medications that we use during surgery. And so that is not an issue, and they recover well in familiar surroundings. So the experience for a lumpectomy is that there is minimal pain. There will be either 1 or 2 incisions after the surgery. And we typically put glue over the incisions. There are no big dressings to take care of. You can get that incision wet in about 48 hours after surgery. And I actually tell my patients to have normal range of movement. So I tell them to do shoulder exercises, which again are on my video out there, and also stretching exercises for the upper limbs so that they're not restricting their movement, because the limitation occurs in the armpit where they keep it tight, and before you know it, they are not able to lift up beyond 90 degrees.
So I want them to be as normal, as limber as possible. At the same time, avoid contact, sudden sharp impact into that area, because that could cause bleeding to that area. So really a good support bra, and just being logical, sensible about the activities you do. Don't start a sport you haven't done before, or don't start, playing soccer the next day. That's not logical. So I would tell them to do normal activities, go for walks and things, stay away from doing heavy strength training for upper extremity for the next few weeks, because I don't want them to drop something on the incision, because then it will bleed. It's a raw tissue, raw area that we just did surgery on. With a mastectomy, recovery is a little bit longer because they have a drain, and that drain stays in for 2-3 weeks sometimes, and that becomes the management issue, is they have to manage the drain, record it, empty it, and so on. But it is there for a reason, because we don't want the body to push fluid into that area where we had surgery. So little bit longer recovery for mastectomy, but again, I want them up and about right away, walking about, doing their normal activities at home, just not doing strenuous activities. And usually after lumpectomies, they go back to work within a week, unless they are doing heavy lifting at work, in which case I ask them to hold off on that sort of work for about 2 to 4 weeks, depending on what kind of job they do. But really, anyone with a desk job, usually 1 week is all they really need or want most of the times.
Okay, and for those patients who are going to undergo reconstructive surgery, are they going to need an expander during their surgery?
So an expander is like a placeholder that is put into the space where we've done the mastectomy, and plastic surgeons put that in. And there are many different reasons for putting an expander in. Sometimes patients want to have a larger sized breast than the one they have at the present time. So that requires some expansion of the skin, or even the muscle if the implant is going to go under the muscle. So that takes time to do. So that's why an expander is put in place, and then they are expanding it over time so that eventually it gets exchanged over to an implant. So that's done by plastic surgeons. The other time an expander would be used would be if there is a breast cancer diagnosis and there are all these other treatments that are going to be required as part of it, which is such as chemotherapy and radiation. All of them have a potential to affect the healing, and we don't want to delay doing those treatments for the sake of completing expansion and putting in an implant. So many times an expander is left in place until all of the cancer treatment is done, and then subsequent to that, the woman can choose to have any different type of reconstruction, anywhere from implant-based or even to a DIEP flap, which is the autologous flap reconstruction. So a temporizing measure. So a tissue expander is a temporizing measure done at the time of mastectomy. So we are able to save out all the skin that we did during mastectomy and use all that skin later when it comes time to do the final reconstruction.
Great, that's helpful information for our patients. Now, for our patients who are going to have reconstructive surgery, you offer a referral to plastic surgeons, but they can also select one themselves. Is that correct?
Yeah, absolutely. I have several plastic surgeons in town that I work with and I have had great results with. And so we definitely give them that list. But yes, there are many times when patients will come in and say, oh, my friend had surgery with so-and-so, and would you work with them? Yeah, we definitely try to work with different plastic surgeons.
Okay, great. Now, for our patients who need radiation as well, who are the best candidates for that treatment?
So the people who definitely will need radiation are patients who have chosen a lumpectomy and are less than 75, 80 years of age. Beyond that age group, it depends on their health and what they can tolerate in terms of different treatments. But less than 75 or 80 years of age, we typically will recommend doing a lumpectomy and following it up with radiation, because that combined together, that's called as breast conservation surgery, which together, the combination of surgery and radiation in the breast makes it equal to having had a mastectomy. So the outcomes, the survival is all the same. The local recurrence is also nearly the same. So patients with lumpectomy will always need radiation. Now, the other group that definitely needs radiation is people who have disease that is found in the lymph nodes. So when we do the surgery for cancer, we also evaluate the lymph nodes in the armpit. And if there is disease in those lymph nodes, then there is an indication for doing radiation to that armpit, and the higher levels in the armpit and the shoulder region where we cannot reach surgically. So if there should be suspicion of disease there, that gets treated with radiation. And that's the case whether it's a lumpectomy or a mastectomy. So for either of those, if there's disease in the axilla or the armpit, then that's a reason for getting radiation. And the side effects are, do you feel maybe tired during the treatment? You may have a little darkening of the skin on that side, a little thickening of the skin. Sometimes people might get sunburns, and there are treatments for that, creams and such. And long term, there may be a little more sensitivity on that side in the skin and the tissues and the chest wall that happens. But usually it's tolerated quite well.
And for our patients, who are the best candidates for neoadjuvant treatment?
That's a great question. So there are, as I said in my talk, there are different types of breast cancers. So the ones that are best suited for neoadjuvant chemotherapy are the ones that are triple negative, that is ER/PR and HER2 negative, or they are HER2 positive cancers. So they could be ER/PR positive and HER2 positive, or they could be ER/PR negative and HER2 positive. So these categories of patients do very well with neoadjuvant chemotherapy because we have targeted therapies that work extremely well. We are able to see the tumor shrinking down in front of our eyes within 2 or 3 treatments even, and oftentimes it's a dramatic response with complete resolution of the tumor, both in the breast and in the armpit if they have disease in the armpit, which means when the time comes for surgery, we are able to tailor the surgery to the amount of residual tumor or the area that was originally diagnosed is left. And oftentimes that's a much smaller area than if we were to operate before chemotherapy. In the armpit, it allows us to do a more selected removal of lymph nodes rather than having to remove all the lymph nodes in the armpit, which is what we might have had to do if we were operating before chemotherapy because all these lymph nodes were enlarged and involved with disease. So chemotherapy helps to what we call as downstage the tumor and allows us to use a more selective approach to removing lymph nodes so that we minimize the risk of arm swelling or lymphedema that can happen afterwards. Because when there's cancer in the lymph nodes, like I just mentioned, radiation is a given. So that combination of a very aggressive surgery in the armpit followed by radiation increases the risk of lymphedema quite a bit. So we would like to minimize that and also the range of movement issues that patients have.
Are there any side effects that our patients may experience as a result of doing endocrine therapy?
So I was just talking actually about chemotherapy, and there are a lot of side effects to chemotherapy, hair loss, loss of taste, loss of appetite, there is weight gain, and many issues like neuropathy and so on. And there are treatments for most of it, but some of it, has to be sort of tolerated, knowing that it is being done for the reason of shrinking the tumor or even making it disappear. As far as neoadjuvant endocrine therapy goes, it is something that is used for cancers that are estrogen and progesterone receptor positive. Typically, it tends to be used more in older women who may not tolerate chemotherapy at all. But these days, we are able to combine the neoadjuvant endocrine therapy, which is like the anti-hormonal therapy, so hormone blocking drugs, with some immune therapy, which is really very effective and sometimes even as effective as chemotherapy in shrinking these tumors. And so we are able to achieve similar results with being able to downstage the tumor and being able to do a smaller operation.
Great. I imagine that's very helpful for our patients. Now, are there any other important points with breast cancer and the breast cancer surgery that you'd like to address with our patients?
A lot of times people feel quite paralyzed with the decision of, what surgery to do and so forth. So I always tell them that ultimately, at the end of the day, it's the decision that's going to let you sleep at night. So, I always give them all the data, all the science behind why we recommend what we recommend. But at the end of the day, if it's your body and it's your decision about how you want the cancer treated. And so I would listen to the advice from everyone, because you tend to get advice, whether you seek it or not, oftentimes from a lot of people, but ultimately you should do what feels right for you. So ultimately it should be a personal decision.
Great. Thank you so much for being here for our patients and for this educational video. We appreciate you joining us today, Dr. Vaidya.
Thank you for having me. Have a great day.
Thank you. You as well.
Thank you for joining us for our virtual Lunch and Learn series. We hope you enjoyed this session. There will be a replay of this Lunch and Learn on the Ironwood YouTube and social media channels. For more information regarding our supportive care services classes and events, email us at wellness@ironwoodcrc.com. Thank you for spending time with us today.